We're going to start with our high-risk topic. Today we're going to do high-risk antepartum and all the stuff that we would see in the antepartum period. And then Monday we'll do labor, and next Thursday we'll do postpartum and all of this, all the high risk of that area. Okay. The high risk for this for today, it's broken up into two sections. So we've got your pregnancy-related complications, and then we have your select groups, so specific groups that are going to be at risk. And that's when we talk about diabetes and patients with cardiac issues and stuff like that. So we'll get to that a little later this morning. So when we start talking about high risk, we're going to start to talk about any type of condition that would put that patient who's pregnant now in a situation of either having to have an emergency delivery, which then complicates her to being able to either most likely have a preterm infant, or puts the mother at risk for maternal complications.
Is this chapter 19?
19 and 20,
okay,
yeah.
Thank you.
So the first thing we're going to start with is sections that occur, like bleeding during pregnancy. And the things that we're going to talk about with bleeding during pregnancy are going to be things like spontaneous abortion or miscarriage, which is the layman's terms for spontaneous AB. You have ectopic pregnancies, gestational thromboplastic disease, or molar pregnancy. We'll talk about that. Cervical insufficiency, placenta previa, and abruption. And those are all having to do with bleeding. So things that will cause bleeding in that antenatal period. So in that pregnancy term, within those 40 weeks. So we start off with spontaneous abortion, and spontaneous abortion is going to be pretty much a pregnancy that ends as a result of natural causes. So she doesn't do anything to initiate the loss. She's pregnant. She's 12 weeks. She thinks everything is going okay. She just probably found out. And then all of a sudden she starts to bleed. Okay? And then the baby passes through. So it's before 20 weeks. Why 20 weeks? What's 20 weeks? What is 20 weeks? It's the age of viability. Right. So remember, our babies cannot survive outside of mom under 20 weeks. Okay? Even at 20 weeks, it's really, really, really hard to keep a baby alive at 20 weeks. You're at age of practice where we keep our babies mostly alive is somewhere between 23 weeks or so. Okay, it's the earliest babies that have really been kept alive. But under 20 weeks, we definitely can't. That baby is not completely mature in order to be able to survive outside of mom. So when those babies pass and those babies are delivered, yes, they may still have a heartbeat, okay? But they have a heartbeat for a very small amount of time. Okay, so it's either just a few minutes until the heartbeat stops, because the fact that they cannot sustain themselves outside of mom and the nutrients and the oxygen that the mom provides through the placenta. And also, babies usually at this point need to weigh at least 500 grams. Now, that's really kind of like an old diagnosis for a spontaneous AB, because we could have multiples, like when you have babies that are like more than just twins, when you're talking about like triplets and quadruplets and quintuplets, where you've got 4, 5, 6 babies in a utero, okay, they're not all going to weigh 2 pounds, 3 pounds, okay, because that'd be a whole lot of weight. So you could actually have, quintuplets that one of them may weigh 490 grams, okay, but be 29 weeks or 30 weeks or 31 weeks. It's just that they're so tiny because there's so little room. There's 5 of them in there, okay? So sometimes that weight thing is kind of relative. So we are, nurses have been known to kind of tip the scale a little bit to make it weigh 500 grams at least, right? Because we know that this baby's out crying, screaming, yelling, moving around. It's 29 weeks, okay? But it weighs 490 grams. So technically we're like, oh, it's under 500 grams. They're going to say, well, it's not a viable fetus. But we know it is because the baby's doing really well, okay, at least for a 29-weeker. But it's because it was one of 6 or one of 5, okay? And that's usually when that happens. It doesn't really happen most of the time with singletons. Okay, with singletons, the weight usually has to be 500 grams or more, because that's usually the weight of a 24-weeker, 23-weeker, somewhere around that age. Okay. So, reasons why we have first trimester losses, or risk factors for first trimester losses, you're going to be your endocrine imbalances. So, remember in the beginning when we talked about that whole hypothalamus pituitary axis, right? Hypothyroidism is the thyroid is an organ that can cause endocrine imbalances and can kind of shift that that scale and shift that balance where you're not producing enough progesterone to maintain that pregnancy. Okay, and remember that we talked about that progesterone becomes your endocrine, your hormone that is going to help maintain that pregnancy. So if you don't have enough progesterone in circulation, you may not have enough to maintain the pregnancy. Same thing with IDDM. So your insulin-dependent diabetic moms, in those first trimesters, they are at risk of having miscarriages or congenital defects because of the fact that they're not controlled diabetics. If they have really a lot of fluctuations in their blood sugars and they're not well maintained, they're going to have issues. So those endocrine imbalances are one of the major risk factors. Immunologic factors, systemic disorders, and genetic factors all fall under that. And those are all risk factors for having that first trimester loss. In that first trimester, when things are developing, when the organs are starting to form, when the baby is starting to first be created, is when all of these factors start to come into play. Okay. Second trimester losses are going to be more related to sometimes certain races or ethnicities can have a higher risk factor. Poor outcomes in the previous pregnancy. So if you have a mom that's had 2-3 losses in the past, she's going to be at risk for another loss. We may not know why she's having the losses, but it's going to be something that she is going to be at risk for again. Maternal age, younger than 15, over 35, they both have the same amount of risk. So your young patients and your older patients, okay, are going to have the same amount of risk for second trimester losses. Severe dietary deficiencies, and you're morbidly obese. So again, both sides of the scale. So your very malnourished patients and your very obese patients are going to have the same risk factors, okay? It's the amount of estrogen or lack of estrogen that causes those losses. And then regular or excessive alcohol use also is one of the risk factors. Any drug use as well could be put in there as well, not just alcohol, but any type of other recreational drug can also be placed in that same category. So the types that we have your threatened, your inevitable, your complete, incomplete, complete, and missed. And basically it's just telling us where we are in the spectrum of a loss. So if you have a threatened, just think, okay, she's bleeding, right? So she has the possibility of having a miscarriage. Her cervix is doing something that's changing. She's bleeding actively. We don't really know why she may be bleeding or not. So this is what we call a threatened AB, okay? Because the possibility of her losing the pregnancy is there. Not that it has happened yet, but it is a threatened. Inevitable means that no matter what we do medically or intervene, it's going to happen. When? We don't know, but it will happen. Inevitable is your patient that comes in, she's, let's say, 18 weeks gestation. She was complaining of bleeding. We check her, and she's 3 centimeters dilated. Okay? And she's 18 weeks. That baby's going to fall out of that 3 centimeter cervix. It's less than 500 grams. Super tiny. The whole sac and everything, even with the baby still alive, will fall out of that cervix, especially if it continues to dilate. Okay, so those patients we want to bring in because at first she's a threatened, right? And we're like, oh man, what can we do? So we could try to maybe do a cerclage, right? When we kind of sew up, okay? And we'll talk about that in a little bit. But we'll try to do a cerclage to see if that will help. right? But then let's say that doesn't help and she continues to dilate. Once she gets to like 4 to 5 centimeters, that's it. There's nothing really we're going to be able to do. We can't close it up because it's too wide. It's too dilated already to do a cerclage. Cerclages are only good for maximum 3 centimeters. So anywhere between being closed or 1 to maximum getting to 3. After 3 centimeters, the cervix is so dilated that you're not going to be able to get enough of that cervix to close it up and stitch it. Okay, so also you're inevitable. It could be that the baby's heart rate is failing, or we don't have a heart rate, and eventually the baby has to be is going to be expelled from the uterus. Okay, so that's another one that would be considered inevitable. Okay, incomplete, complete, and missed are all going to be stages of a miscarriage of how much of the products of conception have been expelled already. So you've basically got your incomplete, meaning that the baby came out, but the placenta is still in there. Or something is left still of the products of conception. So not all of the products of conception came out. So when that happens, we have to go in and evacuate everything. Because remember, anything that's left from those products of conception is going to cause your uterus to what? What is it going to cause your uterus to? It's going to be boggy. A boggy uterus, what does it do? It bleeds. Okay? So we can't leave things in there. Okay, so if not all of the products come out, she could be home. She could say, oh, I went to the bathroom and this came out. And she'll bring the products in the, in a tissue to the hospital. That's what they usually do. They'll see the tissue, they'll see the sac, or maybe it's a yolk sac, and it's like 12 weeks or so. They'll bring that, but not everything came out. So when you do an ultrasound, you still see placenta in there or products still in there. Okay, so that's an incomplete. A complete, just what it sounds like. Everything came out. Okay, so there's nothing left inside. We don't have to do a D&C or anything, and we could send her home a few hours later. Okay, and then missed is where the baby's heart rate somewhere along the line. We usually like to be able to do a D&C and get it over with in a way to help her start the grieving process. And then symptoms. So symptoms that you're going to see is, of course, your vaginal bleeding. It can start off as spotting. It could start off of having like mild cramping, and then they pass a clot or tissue that they see in the bathroom, and then they can see it that it's like larger than a regular clot. It's formed. It has. It may look like the shape of a baby or the bean shape, depending on how many weeks she was or how early she was. They could have pelvic cramping, dull backache. For the most part, that's usually their main symptoms. And then falling HCG levels. So remember, your HCG was your human chorionic gonadotropin hormone, right? That's your hormone of pregnancy. It's produced by the placenta. So if she goes into her first visit and she says, oh, I'm having some spotting, they're going to do an HCG level. And 2 days later, they're going to do another one. And they want to make sure that it's doubling, okay? Now, if it's not going up and it's coming down, then that's a sign that the pregnancy isn't viable and that it's not, that it inevitably it's going to probably be passed. So falling HCG levels are a thing that we would do because we would see how far down it's going to the point that either has she passed everything out completely yet, or she hasn't and it's missed and we have to go in and do a D&C. So with falling HCG levels is our way of being able to tell how the pregnancy is doing. Is it actually doubling and growing, or if it's not? Treatments that we do for these patients is, again, it's going to depend on the type of miscarriage. So I've talked a lot about having a D&C done, and usually that is one of the options that we do. Expectant management can be the other one. If she's in the hospital, she comes in, she's 18 weeks, she's bleeding, we're going to keep her in the hospital until she passes it, okay? And we won't send her home until after it occurs. We do a bleeding assessment on these patients, so we want to make sure how we see, how much bleeding she's having. We check her pads because sometimes the fetuses are so tiny, like you see in that picture, that they can pass and they could almost resemble a clot, or they could be wrapped up in a lot of other blood that kind of sits in the vagina. So she may not know what to look for or what she's seeing. So we check the pads a lot to make sure that hasn't passed the fetus already. IV therapy, we're going to keep them hydrated. We're going to make sure that they're not dehydrated, that if they're bleeding, that they're not bleeding too heavy. And then again, the surgical intervention is our DNC. Again, RhoGAM becomes very important. If your moms are Rh negative, they're going to get the RhoGAM injection for them for their subsequent pregnancies, to protect their pregnancy in the future, for this type of occurrence. So if they have any type of bleeding, wherever there's bleeding, there's always a chance of having some type of exchange of blood. Because it has that chance of exchange of blood, you're going to give them RhoGAM. And then again, a lot of emotional support and grief counseling. We have a very good up and growing RTS program at Meets Countryside. We're really kind of revamping it, and we're doing a lot of things to be able to give these moms things that they could take home with them. They're not taking home their baby, but we could give them a lot of things from memory-wise that will help them to use as part of their grieving process. And our two nurses that have been in charge, that have taken over our RTS program, are really they've gotten grants from the state for a lot of RTS things. So pictures and little mementos and memory boxes and ways to take pictures with certain clothing, and they keep all the blankets and the clothes and stuff like that. So it's really becoming a much more patient-focused program that we could be able to provide them with the grief counseling. Beforehand, we really didn't know. We used our perinatal loss doulas that work out of Bayfront for their miscarriages and their losses, and they used to come up to Meets Countryside. So they did a lot of this for us. And us as nurses really didn't have to be part of this aspect of their care, because the doulas came and did that for them. And they did all of the stuff that we're doing now. So the pictures, the memory boxes, the clay molding of their feet, those kind of things. So we really have come a long way, because the doulas don't come up to us anymore. We're too far north for them. So now we have to be able to kind of do it ourselves. And the two nurses that have taken over have done a great job in trying to rekindle a lot of this stuff and be able to teach us, the regular staff, what's available for them and how to do it. And they'll actually come out of their way to do it for us if we don't feel comfortable doing it as well. So you have ectopic pregnancy. Now remember when I said that when you have a pregnancy, the egg, once it's fertilized in the fallopian tube, it travels through that fallopian tube and it embeds itself in the wall of the uterus, right? The wall of the uterus prepares for the egg, and it builds up that nice fluffy bed. Now with an ectopic, it is that fertilized ovum that now implants outside of the uterus. Okay, so it implants anywhere outside that is not the uterus. So 90% of the times, it's located in the uterine tube. Somewhere it gets stuck in the tube. Okay, so instead of being able to travel through the tube and end up in the uterus, it gets stuck in the tube and stays there. Okay, and it starts to grow. It can only grow to about 8 weeks, 8 to 10 on the most part, before mom starts to feel severe pain. Okay, in her adnexa, whichever one of those fallopian tubes it's stuck in. Okay, because the tube is only, remember I said, it's like the size of, it's less than a straw, right? It's less than the size of a straw. So once this egg starts to multiply and starts to grow, it's going to reach a point where it's too big for the tube. And as it starts to stretch out the tube, okay, it's going to stretch it out to the point where now the patient starts to feel pain and can end up causing rupture of that tube. Okay, so classic symptoms are going to be abdominal pain or lower pelvic pain. They're going to have, of course, a delayed menses because they are pregnant. So somewhere it's either very early in their pregnancy, they should have gotten a period, they didn't. Okay, so they know they're pregnant. But when we do an ultrasound or and their blood levels are going to be the same. So their HCG levels, their pregnancy test is all going to come out positive, the same way that it would normally come out if it was implanted in the uterus. The difference is that they're going to have vaginal bleeding or some spotting, and they have this lower pelvic pain. Usually it's always on one side or the other, okay? And it's really severe to the point that that's what brings them usually into the hospital, okay? Once they come in and they ask them, okay, when was your last period? They say, oh, well, I missed my period this month. They do a blood test. The HCG level is positive, so we know they're pregnant. They do an ultrasound, and they see nothing in the uterus. Okay, so when they go up to the fallopian tubes, they see it in the tube. Okay, if it's still in the tube and it hasn't ruptured, we need to evacuate it. Okay, so it cannot stay there. It can't grow. The unfortunate thing is that we can't take it from there and move it into the uterus. Okay, so once we've evacuated it from the tube, she's no longer pregnant. Okay, we can't move it, okay, or transfer it to the uterus. So we either have to open up the fallopian tube, incise it, remove all the products of conception, and sew up her tube again, or cut her tube if it's too big, and then try to reanastomose it. Or not, if we can't reanastomose the tube, she loses the function of that tube. Lucky she still has another one, okay? And then she'll only end up getting, her fertility will then be affected because she'll only be able to get pregnant from one side. The other side won't work. The way we diagnose it, like I said, vaginal ultrasound, progesterone levels, and beta HCG levels are all going to kind of tell us that she's pregnant and what's going on. Management, like I said, 40% of women will have a medical management. We can give them methotrexate, which helps to dissolve the products of conception that are in the tube. That is the safest way to be able to do it because it dissolves the products of conception, but it helps to maintain the patency of the tube. Okay? So it doesn't allow the tube to create scar tissue. When we go in and do surgical intervention, if you notice your picture, right? Here's your egg. Here's your egg, right? And then when you have your egg, you have your, you make an incision, you remove all the products. Hmm?
Where are you drawing?
Oh, here. I know it's not working for me here either. All right, let me go with this side. All right, so here's your egg, right? Ovary, uterus, fallopian tube. Here's your egg. You make an incision. You're removing all of the products of conception, right? And then you're going to sew up. Once you remove it, you're going to sew up your tube again, okay? Now, if I'm sewing it up, even if I'm using the smallest suture, the most dissolvable suture, what's it going to leave me with? Scar tissue. So if she has scar tissue, what is she going to still be at risk for? Another what? Another ectopic. Right? Because now there's scar tissue in that tube and she gets pregnant again and it tries to travel through the tube, it's going to get stuck in the scar tissue. Okay, so doing a surgical intervention like that leaves her at risk for another ectopic pregnancy, which is what we don't want. So that's why methotrexate, which helps to dissolve the tubal pregnancy, is a much better outcome because it won't cause the damage to the fallopian tube that the surgical intervention will. Okay, so that's why we try to stick with the methotrexate instead. All right. Gestational trophoblastic disease. Wow, big words, right? Easiest known as molar pregnancy. Okay, it's a lot easier than gestational trophoblastic. Now, a molar pregnancy is basically your benign proliferative growth of placental trophoblast. So basically what it is that egg traveled down, right, implanted in the uterus, but somewhere along the line, either genetically, either two sperm ended up penetrating one egg, or when it started to split, it started to have an abnormal proliferation of the splitting of the cells, okay? Where now you've got all this DNA information, all this DNA tissue, and you're just having a proliferation of cells. So you don't have a formed fetus. So in this situation, the baby is not formed. There's no baby. All there is DNA tissue. Okay? So when you have DNA tissue, you get like these clusters. In that top picture, you'll see that you get like these clusters where you just have all of these grape-like clusters, and they're filled with fluid and DNA tissue. Now, DNA tissue is what makes us, right? So DNA tissue is nails, hair, teeth, okay? So when we evacuate these molar pregnancies and we remove them by a D&C, the things that we're going to see are going to be DNA products. So you're going to see pieces of hair, pieces of teeth, fingernails, okay? Those kind of things, because that's part of the DNA tissue. And then when you have all of this proliferation, it just kind of multiplies into these cells. We talked about this once before when we talked about issues with the pregnancy. With manifestations of molar pregnancies, you cannot distinguish them between a regular pregnancy and a molar pregnancy, especially in the very beginning. So in the first few weeks of pregnancy, she could come in. She could say, yes, I'm 12 weeks. I missed my period. We calculate LMP. She's 12, 14 weeks or so. It's going to look the same as a normal pregnancy. There's going to be no reason that we would indicate that, or for us to be able to say that we're suspicious of it being a molar pregnancy, okay? Because at this point, everything looks exactly the same. And it's not the same inside, but there's no reason for us to look inside at this point, or to be suspicious and give us a reason to look inside, okay? Her second visit now, she comes in, and remember in the beginning, our visits are 4 weeks apart, right? So if she comes in her first visit, she's like, let's say 10 weeks. Now she's going to come back and she's going to be 14 weeks, right? But when we measure her now at 14 weeks, she's measuring 22 weeks. And we're like, what the heck? Right? Like, what just happened? She was just 14 weeks. Now she's measuring 22 weeks. Are the dates wrong? What's going on? You know? And so that's going to cause a red light to occur. And that's when we're going to be like, let's go see what's going on. And that's when we'll do an ultrasound. That's when we do blood work for HCG levels. Okay? And when we get our blood work back for our HCG levels are like through the roof. Like out the window, through the roof, and like touching the sky. They're so high. Okay? They're like 5 times higher than what we would normally have. Okay? And then we get an ultrasound, and all we see is a snowstorm effect. So all we see is this cluster of cells. Okay? So in an ultrasound, it's just going to look like a snowstorm effect. It's going to have all this like white kind of like shadowing on the ultrasound. And there's not going to be any distinguishable effect in that ultrasound that's going to say that there's a fetus and a placenta or a yolk sac or anything like that. Patients will also either be anemic because, again, everything is proliferating so quickly. It's using a lot of the patient's red blood cells. She could have excessive nausea and vomiting because of the elevated HCG levels. Okay, so her HCG levels are so high that it's causing her to have severe excessive nausea and vomiting, or hyperemesis. Abdominal cramping. She could even start to have signs of preeclampsia, which is elevated blood pressures with protein in her urine, and she'll have hyperthyroidism. So all of those things are going to be things that we're going to see in this patient. But again, that first visit, there's not going to be any reason for us to notice or know that this is occurring. It's probably going to happen once in that second visit, when we start to measure her and we see that she's measuring way higher, way bigger than what she should. Follow-up. Again, we're always going to do a physical. We're going to do a pelvic exam. We're going to do weekly measurements of her beta HCG. So we want to make sure that there are tripling, that they're going up. However, we also want to make sure that it hasn't changed any. So before we kind of really say, yes, she's having a molar pregnancy, we really need to make sure, because remember, the surgical intervention is going to be to evacuate everything, because it's really not a baby. But we want to double check and make sure that that's where we're at. Okay? So it's not going to be as easy to just say, okay, yeah, you're having a molar pregnancy, do a DNC. Because just by HCG levels, we're going to have to really kind of study it and look at that ultrasound, because we want to make sure that it's not twins or multiples or something to that effect that's causing that HCG level to rise so high. So one alone is not the way we diagnose it. We need to have a correlation of both of them. These patients are going to be at higher risk for choriocarcinoma, which is a cancer of the uterine lining. These patients need to be followed up for 1 full year, and they cannot get pregnant for that 1 full year. Okay, because remember, HCG is the way that we kind of like what we use in order to detect if the molar pregnancy, if her body is kind of not going through that proliferation of cells anymore. So if she gets pregnant and the HCG levels start to rise because of normal pregnancy, we're not going to be able to tell the difference, whether it's because she's got choriocarcinoma or whether it's because it's a pregnancy. Okay, because the HCG levels are just going to keep going up. So we really recommend that these patients wait the full year before they can try to conceive again. Okay, because it's to their benefit. And then RhoGAM, of course, if it's indicated, if they're Rh negative. Biggest thing that you need to know with molar pregnancy or gestational tropoplastic is that you have the snowstorm effect that you see on your ultrasound. You have the excessively high HCG levels, which those two together is what helps to give us a diagnosis. They have the risk for choriocarcinoma, and that they cannot get pregnant for a full year. Okay, and that's going to be part of their teaching. Those are your most important aspects. All right, so I touched on this a little bit before with cervical insufficiency. It's an incompetent cervix is what we usually call it as well. It's a passive and painless dilation of the cervix, which leads to recurrent preterm births somewhere during the second trimester, results in spontaneous abortions or a very preterm infant. Now, an incompetent cervix is, like I said, your hinges on your door are weak. Okay, so your cervix is your door, the hinges are weak, the baby starts to grow, right? It starts to get heavier, and it's putting all this pressure on the door that has weak hinges. What do you think is going to happen? It's going to open, right? The door's going to give way. The door gives way, it starts to dilate. Okay, as it starts to dilate, then patient doesn't really feel anything. It's not causing, the dilation's not being caused by her contractions. Okay, her dilation is just being caused because the hinges on her door are weak, and the weight of the baby alone is opening the door. Okay, unfortunately, with an incompetent cervix, we usually cannot diagnose it until she's had at least one preterm delivery or a miscarriage. Okay, if she's had a miscarriage at, let's say, 14 weeks or 15 weeks, and we don't have a reason why, there was no real genetic issues, there was no real problem, she just came into the office one day, you checked her, and she was 5 centimeters dilated or 4 centimeters dilated. Okay, that can raise a red flag. At that point, we really can't do anything about it. It's going to be one of our inevitable ABs. Okay. But for the next time, we can kind of think about that and be like, she's probably going to be a good candidate for a cerclage because she's got an incompetent cervix. You know, unfortunately, lots of times women don't even follow up. They have a miscarriage. They went to the ER. Everything came out, right? Because it happens so early, and they get pregnant again, and it happens again. They could end up having 2 or 3 miscarriages before someone actually says, I think you have an incompetent cervix. Okay? So unfortunately, that's usually how we that red flag starts to kind of get raised, because of the fact that they've had so many abnormal abnormal amount of losses. Things that can cause an incompetent cervix, again, you have your congenital issues. DES, I'm going to probably stop using it, because DES, by this time, we have no generations that are left that their parents used DES. It used to be a medication that was put in prenatal vitamins back in the 70s, back in the late 60s, mid 70s, that was said to be able to help with maternal growth and fetal well-being and all this other stuff. So they put DES. What they didn't realize is that DES was causing female babies to be born with congenital reproductive issues. So they would be born with bicoordinate uteruses, like uteruses with a stem in the middle. They would be born with two uteruses or no uterus and have ovaries. So a lot of congenital issues with the reproductive system on their female offspring. So they took it off the market. They stopped putting in the prenatal vitamins, but we still had a whole lot of generations of women that were born in that era that were having issues with their uterus. And so at this point now, we've it's been so long since it's been out of the market that now we don't have any generations of women that have this in their past anymore, or that their moms use this anymore. So those women are past the reproductive age at this point, and so they're not producing any more children. Collagen disorders or uterine abnormalities are all going to be reasons why you might have an incompetent cervix. Risk factors, if you've had previous cervical traumas, lots of patients that have issues with their cervix before they conceive. So like if they've got abnormal pap smears, that they had a LEEP procedure done, or they had some type of procedure done on their cervix, they tweaked and they messed with the cervix. Okay, so they messed with the doors of that hinge. All right, and so then now when you want the door to work, it doesn't work because someone before then was kind of messing with the door. Okay, so they usually have these problems as well. Preterm labor, like I said, if you have a patient that's having all these early deliveries or early preterm labors, it could be a sign that their cervix is incompetent. Fetal loss in the second trimester or history of losses at 20 weeks or so is going to be your clientele for these patients. So diagnosis, so we can visualize the cervical opening. So we put in the speculum, we could actually see the cervix open. The uterus and the ultrasound, and the cervix is then done by ultrasound, and we could test the cervical length. So remember, the length of that door should be 4 centimeters. Okay, so your length of your cervix, of a normal cervix, is about 4 centimeters long. Okay, anything under 4 centimeters before she gets to be of age of viability or term, okay, it's going to be a cervix that's shorter. If your cervix is shorter, that means it's thinner. So it's not as thick as it should be. And those are going to be the patients that are at risk for an incompetent cervix because they already have a shorter cervix, okay? And then history, again, of second trimester losses. That's usually going to be our first key. And how we manage it, again, is your McDonald's or your Schutterkar cerclage. You don't need to know their specific names. That's just the names of the men who figured out how to fix it, okay? And the reason why there's 2 is because both of them figured out different ways to stitch the cervix, okay? So one of them stitches it kind of sideways, like if you were sewing like a hem. The other one uses like this kind of like rotating kind of aspect where they kind of close it all and kind of make it into like a point. It's just different types of stitching on the cervix. So that's why there's 2 different types, but they're all being the same thing, okay? It's all a cerclage. You're basically getting sutures, and you get the door, Okay, because if you see the picture, here's your cervix, right? See, this is one of the Schroeder. They take it, they put a suture all the way around it, and then they kind of squeeze up, and it leaves it kind of like almost like sticking out, but it's closed at the end. Okay, and so now it's shut. Okay, that suture doesn't dissolve. Okay, that suture has to be cut. Okay, when she gets to be 36 weeks. Okay, because what will happen is that if we let her go into labor on her own, right, and then she starts to dilate and that suture's still in, what's going to happen? What's going to happen to the cervix?
It'll rip.
It'll rip, exactly. Okay, because it's sutured closed, and now we're trying to force it open, right? And it's just soft tissue, so it will rip. Okay, so we know, if we know it at 36 weeks, we go in with a speculum and we cut the stitch. Okay, and we remove it so that way she can go into labor all she wants now, because she's 36 weeks. Okay, and at this point the baby is viable and will do well. But you don't want to take it out before she's viable or before the baby does well. Now, if she comes in and she's huffing, puffing, because she's contracting, we can't stop her contractions. She's 30 weeks or 32 weeks. We're going to cut it, okay? Because if we can't stop her contractions, we don't want her cervix to rip. So we're going to cut it, and we're going to let her deliver if that's what's going to happen, okay? But it's better than her delivering at 18 or 20 weeks or 21 weeks at 30 weeks, okay? So 30 and 31 weeks is a much more better chance of that baby surviving and doing okay than 21 or 22 weeks, okay? So that's why we do that. Tocolytics, these patients are usually given medications that will help to relax her uterus. So those are meds that are going to stop her from contracting at all completely. These patients are usually put on bed rest. And so there's no heavy lifting, no strenuous exercise. Sometimes, depending on the position of the baby and how much of that cervix is open and how much is protruding out of it, they might put her in Trendelenburg. Now remember, Trendelenburg, we use gravity to our advantage, right? So if she's like this, standing up, right, this is her head, this is her feet, right, and we keep her this way, if her cervix is somewhat open, gravity is going to force that bag of water with that baby through that open door. Okay, that's just normal gravity. Okay, so what we need to do is, if we need to push all those products back so that we can close that door, we have to put her in Trendelenburg. Okay, so we put her in Trendelenburg, so the gravity now goes back, takes all that area that was protruding out of her cervix back into her uterus. So now there's nothing there. So now the doctor can go in, okay, and suture up that that door, okay, suture up the cervix. Because that way, they're not going to want to keep her, to let her go home. He's going to want to keep her. And we have docs that love to keep them for weeks on end, especially if she's got a really incompetent cervix. So if she comes in and her cervix is like 1 centimeter or half a centimeter, okay, and she's like, and so they did a cerclage and they're trying to keep her pregnant, she's going to be there for the rest of the pregnancy. So if she's 21 weeks, think about it. She's there for another 10, 15 weeks tops. Okay? So she's a permanent resident with us. Right? And that's not easy to handle if you're at the hospital, in a hospital bed, away from your family, okay, for 10 weeks. Okay? So they get a little like bat crazy. They really kind of like start to lose it.
Hormones.
Yeah, they're hormonal. The 4 walls start to kind of cave in on them. Okay, so they start to get crazy. So we need to move their rooms. We do a lot of emotional stuff. So we bring them, things to do, things to read. We've got the Smile program at Baycare where they'll do chair massages, and we do a lot of stuff to try to keep them from going, bat crap crazy, basically. You know what I mean? Because imagine you're there 10 weeks. I would lose my mind, right? If you had to be there 10 weeks in a hospital bed. One, the hospital beds are not comfortable to be with. Plus, you could only see so many people in blue scrubs all the time. And eventually you want to, get outside, So That's one of the big things. So emotional support is huge for these patients. It's going to be one of your biggest things. All right, so placenta previa. Placenta previa is an abnormally implanted placenta near to or over the internal cervical os. Okay, so remember where our placenta now attaches to that nice fluffy bed, right? Now, what happens with placenta previa is that the placenta, instead of moving upward, instead of kind of getting attached to the walls of the uterus or to the top part of the uterus, it attaches to the bottom part, to the door. Okay? So it blocks the door. Now, for the most part, most placentas that start off really low, as she gets bigger in her pregnancy and as she progresses in her pregnancy, will start to kind of migrate up. Because just like a balloon, you start to stretch out the balloon, right? The placenta will start to move along with it. However, with the previa, if it stays there, it's going to stay there. And it's not going to migrate. So what ends up happening is that now she's 37 weeks, 38 weeks, okay? She can go into labor, but what's covering the door is the placenta. So if the door starts to open, what's going to come out? The placenta. Now, can placenta come out first? No. Because the placenta is what feeds the baby, right? It's what feeds the baby oxygen, what feeds the baby all of its nutrients. So if the placenta is delivered first, the baby will die. So we can't have the placenta come out first. We have to have the baby come out first. Okay? So that means that she cannot have a vaginal delivery. Right? So these patients with placenta previa have to have a cesarean section. There's no other way of delivering this baby. Okay? In order to be able to have a safe outcome. Now you have two types. You have a complete previa and you have a marginal previa. Now the marginal previas are your placentas that are kind of like, here's your door, here's your placenta. Which like a portion of it is blocking the door, but not the whole thing. So it's really going to depend on your doctor how much risk he wants to take. How much of that tip of the placenta is blocking the door? Is it enough that when the door opens, the baby's heart rate's going to be affected, and then we might end up having to do an emergency section? Or is it minimal, and we could let the door open, and whatever part is there, even if it detaches first, it's not enough to affect the baby's oxygen supply? Okay, so with marginal, it's really dependent. It's not guaranteed that she's going to end up in a section, but it's something that we need to look for as far as bleeding, as far as baby's heart rate, making sure that that baby's not showing signs of hypoxia. Okay, because that's going to be the key. Risk factors that you have, your moms that are advanced maternal age, your moms who are having multiples. So remember with multiples, if you've got 3 or 4 babies in there, right, you've got very little room for the placenta to attach to anywhere. So that's why with multiples, you probably have a more of a risk of a previa because it just kind of attached on the bottom. They didn't have any other space. Okay. History of a prior D&C or a C-section. Remember, when we go in and do a D&C and we do a previous section, lots of times it leaves a scar. Okay, leaves a scar on the inside of your uterus as well. So placentas tend to kind of like to stick to themselves where there was something else stuck before. Okay, so they kind of migrate themselves almost to where the scar is because that's a bigger, fluffier area because there's scar tissue there, plus all the extra lining. Now the placenta thinks that, that egg that travels down says, wow, this is a really nice fluffy area. Let me use this one. And so they stuck there. And that's usually where the old incision was from the C-section or the old D&C scar that was created. So with that, that's why usually those patients have more history of previous. Smokers, because again, you have a lot of areas of calcification with smokers. They have vasoconstriction going on a constant basis, even in their uterus. So those areas are going to have, there's going to be less areas for the baby to attach to. Okay, and then again with multiples.
You see what you said the AMA is?
Advanced maternal age. The way we diagnose it is with an ultrasound. We can see in ultrasound where the placenta is, where it's attached to. So in all our ultrasound reports, they will tell us that it's an anterior placenta, or it's a posterior placenta, or the placenta is covering the os by this many centimeters. So they can kind of measure, they can tell us exactly where the placenta is, okay? If it starts off with really low, and then they'll do serial ultrasounds to see if it starts to migrate. If it's moved and it's migrated by the time she's, 30 weeks or so, then the risk of C-section is down. But if it hasn't migrated and it's still covering the door, they're going to start planning a C-section by the time she's 38 weeks or so. Manifestations, big thing with this one is that it's painless, bright red bleeding. Mom does not feel any pain. There's no cramping, there's no pelvic pain, nothing. She just wakes up or something, or she starts to see spotting, or she wipes and she starts to see blood. Okay? There's no pain involved with this. And with that, most of the time is because, again, your cervix is the door. It's holding not only the baby, but the water and everything else that's in there. Okay? Now, when you have the placenta blocking the door and the baby's moving around and kicking and putting a lot of weight, it's going to put pressure on that placenta. That placenta is going to put pressure on the door. You're going to have like this kind of like almost like soft tissue injury with that placenta, where that's what's going to make it to bleed. Okay, so that's what we're looking for. We're looking for that bright red vaginal bleeding, and it can happen because she did laundry, or she walked around too much, or she lifted up her other kids. You know what I mean? It doesn't necessarily occur just because she had some type of trauma to it or not. Fundal heights are higher. When we're doing their measurements, okay, we notice that the fundal heights are higher than normal because, remember, the placenta now is on the bottom, right? So you have the placenta on the bottom, the baby on the top. It's like there's a big, like, step on top of the baby. So everything's going to be pushed up higher, okay? And then baby's going to be in a malpresentation. So your baby's not necessarily going to be head down because it notices that the placenta is in the bottom, okay? So most of these babies either stay like transverse, sideways, or breech, okay? And then usually it's butt first that they like. Outcomes, again, if she starts to hemorrhage, we're going to bring her in. If we need to if she starts to bleed too heavily and we can't stop the bleeding, we're going to do a C-section early. If not, we do usually kind of keep her in expectant management by just watching her and not letting her do anything, putting her in Trendelenburg and just keeping an eye on her. We're going to have abnormal placental attachment. Lots of times when the placenta is attached to that bottom, right, remember your aspect of your uterus. So your uterus is like a big, like let's say like a pear, right? It kind of like is really wide and then narrow on the bottom. So if it's attached down here, it's attached to where there's not really a lot of that nice fluffy bed, right? So as the placenta starts to attach and starts to kind of like attach to the wall of the uterus, there's not much there for it to attach to. So that's usually where we get a lot of what we call accretas, where that placenta is actually stuck, embedded into the wall of the uterus, okay? Because there wasn't a nice fluffy layer there for it to attach to. It's actually the walls of that uterus that it attaches to. So you have more chances of that uterus, of that placenta attaching to the actual wall of the uterus, rather than the nice fluffy bed. Okay, and that's what we mean by abnormal placental attachment, that it's not attaching to the fluffy bed, but it's attaching to the wall of the uterus, where when that tries to come out, it's going to get stuck, and it's going to pull from the wall of the uterus, and that's an accreta, where now it's attached to the actual muscle of the uterus. All right, and lots of times patients that have that type of situation end up losing their uterus because it leaves a big hole. Okay, so since it leaves a big hole, we can't close up the hole. It's kind of hard because there's so much wall tissue there, and so she bleeds more. Abruption. Now these two are going to be very similar. And these are the differences that you have to know. If you know your differences, you'll be able to detect one from the other. So abruption is a premature separation of the placenta. So you've got the placenta that now separates prematurely. She was in an MVA, hit the steering wheel, all right? The placenta got trauma to it. It went pop and popped off the wall, okay? Now she's bleeding inside of her uterus, okay? So she starts to bleed inside her uterus. As she bleeds inside her uterus, now their water, baby, and blood are in that uterus, okay? The whole abdomen is going to get rock hard, okay? As it gets rock hard, then she's going to start to feel pain, okay? Because now that premature detachment, now the baby's not getting any oxygen. So those are areas of now hypoxia. That hypoxia is going to cause pain as well. Okay? So you've got detached either part or all of the uterus. So you could have a small detachment of the uterus, or you could have the whole uterus detach itself. So if you notice in your picture, here's your placenta. Right? Here's the outside. This is the fetal side. This is the maternal side. She had the injury, and the little part of it right here detached. Okay? Now, this is partial. This is kind of self-contained. This eventually, the body will usually absorb the blood that it bled. Okay? As long as it's less than 10% of the placenta, we can keep her pregnant. Okay? 10% is really the most the body can handle, or the baby can handle, of the placenta being detached, without causing significant issues with the baby's oxygen level and heart rate. Okay, so 10% is the max. If it occurs more than 10%, the patient's going to bleed. The baby's going to start to have issues with its oxygen level. Now, what could also happen is that it could detach, but it detaches from the bottom part of the placenta, and now this is going to bleed. So she's going to have vaginal bleeding that she's going to be able to see. Where here, she may or may not have vaginal bleeding because it's kind of concealed. So here you may see bleeding, depending on how it seeped down, or you may not. But you may feel her belly a little harder than usual because it's all inside her uterus. Or she might complain of somewhat pain, especially rebound tenderness and stuff when you press on her, because of where the blood is concealed. With this one, you almost always have some type of bleeding because it's kind of like on the lower part and it bleeds out. Okay? With the complete separation, for most of them, it can happen either way. It's either complete and concealed, or it's complete and we actually see bleeding. When we actually see bleeding with a complete abruption, it's not as detrimental because we see bleeding. So whenever we see bleeding, it's a sign of concern, right? So when we see bleeding, we're like, oh, okay, something's happening. We're going to do an ultrasound. We're going to watch for her. But when it's concealed, she starts to have so much pain, and her belly starts to get so hard and we don't see any bleeding. So we're like wondering, okay, well, these contractions, are these not contractions? Let's do an ultrasound. So the treatment may end up being a somewhat delayed because we're trying to figure out what's actually causing the pain. Okay. The other thing that might give us a good indication is the baby's heart rate. So if she does come in because she's like keeled over in pain, and usually that's what they do, they're like keeled over in pain, and they're like it's like one contraction that doesn't go away, right? And they're like so much in pain, they're like crying in pain. You put them on, you look for their heart rate, and the heart rate's 50, and you're like, crap. And you feel her belly, and her belly's like this, like if I'm feeling a table. There's no indentation at all. Okay, first thing I'm going to say is that she's having an abruption because she's in pain, heart rate's 50, and her belly's rock hard. All three things that are going to tell me that she's having an abruption. All right, so I'm going to call ultrasound. they do a stat. As I'm doing theirs, they're doing their ultrasound. I'm preparing her for section. Because what's happening is that she's got minimal amount of time. I can't play with a heart rate of 50. Okay, it's a matter of time, and it's a matter of time and a matter of life and death that I get that baby out. Okay, because if I don't get that baby out, the baby's going to die. It's not getting any oxygen at all. Okay, so that's going to be the key. So with your classic symptoms, again, vaginal bleeding, abdominal pain, uterine tenderness, they could start to contract. The pain is usually mild to severe, more severe than anything else. And again, that board-like abdomen. Now, based on the severity, like I said, it's going to base on the treatment. So if she's completely abrupted, I'm going to section her, okay? And then I'm going to, I'm not going to wait to deliver her. So this is not a patient that you're going to start to induce and try to deliver her vaginally. Okay, it's a patient that you want to deliver very quickly. I'm going to monitor for any fetal distress, and I'm going to monitor for hemorrhage. Now, this mom has been bleeding for a really long time, right? Because by the time she came to us, the travel time from her house or from wherever she was to the hospital, so she's been bleeding for a while. So as your body, and you're bleeding for a while, your body's constantly trying to stop the bleeding. So your body's shooting out platelets, right? It's shooting out all of your PTTs. It's shooting out all your clotting factors in order to stop the bleeding, because your body knows it's bleeding somewhere, so it needs to stop it. What happens with these patients is that after we've taken everything out, right, and we want her to keep, like now we want her the bleeding to stop because we removed the baby, we removed the rest of the placenta, we evacuated all that blood, the body ran out of clotting factors. So when the body runs out of clotting factors, you go into DIC. And DIC happens not just in pregnancy, it happens in med-surg or any type of trauma where patients bleed. When you run out of clotting factors, you go into a process where now your body can't stop itself from bleeding anymore. And you have what they call disseminated intravascular coagulation, which is DIC. Okay, and with DIC, you bleed, and you bleed. Now you can't stop it from anywhere. So you bleed from your eyes, you bleed from your IV sites, bleed from your nose. Okay, because now all the areas where your body would have normally been able to clot its blood, now it can't because it doesn't have any left. Patients will die from DIC. Okay, trying to catch up, and you're trying to get them to a point where they're not, where they're no longer going to be, they're going to be able to catch up with that clotting. And sometimes it's not that easy. And lots of times we could have patients that are young and healthy that we can't catch up, and they end up dying. The worst case of abruption that I saw, or that DIC that I saw, was she was 23 years old, newly pregnant, first baby, newly married, had a baby, ended up with a C-section, and then they brought her to the room because we always do our recoveries in our room. Brought her to the room, and her blood pressure starts dropping. You know, she starts to get cold and clammy. The nurses are kind of looking at her like, what's going on? They start to see that her lochia starts to get heavier and heavier. And then they start to notice that she starts to bleed. She's bleeding from her IV site. And she starts, like, her teardrops are, she's crying and the teardrops are bloody. And so they ended up realizing she's going into DIC. So they start to call platelets, and they start to try to give her platelets. Then she codes, because now she's lost so much blood, she goes into shock. So now she goes into a cardiac arrest. So now they're trying to revise her. Then she stops breathing. So now she's in a cardiac arrest, a respiratory arrest, and they can't stabilize her. They know where it's coming from, her uterus, but they can't stop it. Right now she's into DIC. She's so unstable, we can't get her back to the OR to remove her uterus. Okay? And so we can't remove her uterus. She's going to keep bleeding because she's so unstable. She died after an hour of trying to revive her. Like, they worked on her for an hour, like literally an hour. She was 23 years old. She had just had her baby. Just had gotten married like a year before. So,
Why don't they remove, if they see that that's a higher risk, why don't they just remove the uterus with the baby?
Well, because we don't know. Let's say she didn't have DIC prior to the baby. You know what I mean? It happened after. Like, let's say she went into DIC after she had the baby. because she had the baby. She ended up with a C-section, but her uterus stayed boggy and it started to bleed, and so she ended up with a postpartum hemorrhage, which was caused her to have DIC. So it's hard to kind of predict. If we can get them back to the OR to remove the uterus, which is your biggest source of bleeding, then you have a better chance. But sometimes you don't have that privilege. You don't have that right, because if she's that unstable, they're not going to be able to bring her from the room to the OR to put her under anesthesia to get her to remove the uterus, because she's coding. So we're trying to revive her heart. We're in the middle of a code. So, and you're not going to stop the code to give her an OR, to do the OR. You know what I mean? Because it's just backwards.
If the chances with this are higher for...
With this, because sometimes we could say, remember, if you remove a patient's uterus, yes, you may save their life, but you've also prevented them from having any more babies. So what ends up happening is depending on what's going on, like if she has an abruption and she's 30 weeks, right, and she abrupted, and we took the baby, we got the baby out enough, baby's in NICU, and we're watching her now, right? And we're kind of watching her, and we're trying to hope to make sure her uterus stays nice and firm and she doesn't bleed. What happens is that my goal is to be able to try to save her fertility as well as trying to save her. I don't want to go in and just remove everybody's uterus, because then we won't have a job, right? Because nobody will be able to have babies again. So the point is to be able to make sure that we can provide her with the stabilization that we need to keep her from bleeding anymore, but also to protect her fertility for future cases, for future pregnancies. Now, yes, if this is baby number 5 and she's, bleeding and she's got a postpartum hemorrhage, it's going to be a lot easier to say, let's just go in and remove the uterus, because it's her 5th baby. She's had 5 babies. You know what I mean? She probably got a tubal anyway, so you know why she doesn't need her uterus. Let's just remove it. But if she's 23 and it's her first baby, and we're going to try really hard to save her uterus rather than to just take it out. All right, so that's the thing. And we have things that we can use besides just trying to take it out. All right, so gestational conditions. So these are things that occur in pregnancy that are related to during the pregnancy time. So your first one's going to be your hyperemesis. And everybody knows, basically, or can remember what hyperemesis is. It's your pernicious vomiting of pregnancy. It's just not your normal, how do you call it? Nausea and vomiting or morning sickness. This is basically patients that cannot hold anything down, not even water, okay? They can't hold anything down to the point that they're now dehydrated. They start to lose weight. They start to have electrolyte imbalances, and their body goes into starvation mode, okay, because they're not being able to take anything in. Patients usually with this have a greater than 5% weight loss. They have very poor skin turgor, dry mucous membranes, tachycardia. If you start to notice, those are all your signs and symptoms of dehydration, right? Possible hypotension, increased hematocrit, their poor urine output, increased urine specific gravity, all your signs that your patient is dehydrated or starving. They're not getting any nutrients. And your babies will always try to get the nutrients they need. So they will suck it out of mom before they start to feel any ill effects. So mom is the one who ends up feeling the ill effects rather than baby. When mom starts to have all of these signs of starvation and electrolyte imbalances, that's when baby starts to get affected. But first, your baby's going to always get what it needs. So it will suck it from you before it starts to have any signs of sequela. Once mom is in this state, that now she's suffering from starvation mode and dehydration, then your baby's going to start to have abnormal development. It may not grow the way it should, so it's going to have intrauterine growth restriction. You're going to have a smaller baby, and then your baby could eventually die because your mom's not getting anything. Okay, but those are going to be much later effects on the fetus before mom's going to feel the first symptoms first. Treatments, again, IV therapy. These patients sometimes end up on TPN, okay, with PICC lines that they go home with because they can't tolerate anything by mouth. Ongoing assessments and monitoring. We give them meds to stop with the nausea and the vomiting, and we give them nutrition as tolerated. So basically, again, you want to start off with smaller meals, so clear liquids, see how much they tolerate, then full liquids, see how much they tolerate. Lots of times with true hyperemesis, these moms will end up in with PICC lines on like home health and PICC lines until they're about 25 weeks or so, okay, 25, 30 weeks, before they start to feel any better, okay, and that they could actually tolerate something by mouth, all right. I had a colleague that I worked with. She had 2 pregnancies. For each pregnancy, she had hyperemesis. Her first one lasted till she was 25 weeks, and she went home with a PICC line. Her second one, she was actually 34 weeks before they were able to take away her PICC line, and she was able to eat regular food. And because she was on TPN the entire time. From the minute she found out she was pregnant, she couldn't hold anything down. She started to throw up. And they knew, with the second one, they knew it already. And so she started her on TPN a lot earlier. And but she was on TPN and on home for most of her pregnancy. She couldn't work because of the hyperemesis was just so bad. Even if she tried to drink water, even when she sucked on ice, she would suck on ice. And like if she sucked on too many ice chips, she would throw them out. It was just that bad. So it's just due to the HCG levels and how the body's responding to the extra hormones that's being produced by the placenta that it causes hyperemesis. Blood incompatibility. The types that we see all the time with pregnant patients are your ABO and your RH, isoimmunization. ABO, again, it's very typical of what we would see with a patient in med-surg. If your mom is O pos and your baby is A or B, you're going to have a possibility of having an incompatibility. Okay, there's different blood types. If your mom is Rh negative and your baby is Rh positive, okay, that is your biggest one, because with Rh negative and Rh positive, if you build up antibodies against that blood type, an Rh positive blood type, what will end up happening is that not the pregnancy that you're currently in, but for the subsequent pregnancy, you have those antibodies in your system. So if there's ever an exchange of blood with the next pregnancy, your body's going to say, hey, I recognize this. This is a foreign entity, and I'm going to stop it from affecting my host, right? And it's going to start to build up antibodies and more antibodies against the baby's blood. What it does is it causes hemolysis of the baby's blood. Okay, so then the baby's blood cells and red blood cells start to get broken down, and they start to break down in the baby's blood. And when breakdown of the baby's red blood cells occurs, it causes them to put them under their skin, which causes their bilirubin levels to go up. Okay, when bilirubin levels go up, babies turn yellow, right? The longer this occurs, the more yellow that the baby gets, it could end up going into their gray matter of their brain. And that's called kernicterus, right? And kernicterus is the worst case of your Rh isoimmunization that could occur. It's where you've got bilirubin levels and bilirubin deposits in the brain, in the gray matter, and those babies usually do not survive. They last about a week or two, but their bilirubin levels are so high that their organs start to shut down and their brain doesn't function. Okay, and so those babies will die. And they will come out literally canary yellow, like yellow. We had one case at Meese probably a year ago now. Baby was like neon, glowed in the dark, literally. But it had really bad kernicterus, and it died about a week later because it was just not picked up. Okay, and she never followed up with getting her RhoGAM. Okay, and she was just Rh negative, young girl. So this is something that as providers, we need to make sure that we are educating our patients about, and making sure that if they are Rh negative, that we teach them the importance of being able to have Rogam. Okay, Rogam is a medication. It's a synthetic medication that was created to prevent the mom from creating and the body from creating the antibodies against the Rh positive blood type. So what we do is that we do a type-in screen on mom at the very first prenatal visit because we want to know what her blood type is. Okay, this is what's going to tell us if we need to worry about this or not. Okay, and then we do what we call an antibody screen. And the antibody screen is going to be an indirect Coombs test. Okay, that's the other name that you'll hear it called in the lab. It's an indirect Coombs test. And that antibody screen will kind of tell us whether she's been exposed to other antibodies, whether she's made antibodies against any other blood type. Okay, it's either negative or positive. Okay, if it's negative, we're good. We don't have to worry about it. And we can give her Rogam prophylactically during her pregnancy. Okay, if it's positive, now we have to kind of watch her. And as we watch her, we're going to watch the baby as well for fetal anomalies and for how much hemolysis is occurring. Okay, because sometimes the lines of fetal blood and maternal blood are separated, but they are very close as well. So sometimes the exchange of blood can occur and sometimes it doesn't. So if she happens to have a very non-complicated, normal pregnancy without any exchange of blood or anything, she could probably be okay and not cause any type of ISO immunization or hemolysis. But if she falls or she hurts herself or she has to have a special procedure done, anything that can cause that exchange of blood or that possibility of exchange of blood is what's going to then have a higher risk of causing the hemolysis, because now the exchange of blood occurred. Okay. Nursing management. So if everything goes well throughout the pregnancy, mom has the baby, okay, we're going to send her cord blood to the lab. And now we're going to do what we call a direct Coombs. We're going to do a type-in screen on the baby, and we're going to do an antibody screen on the baby's blood, which is a direct Coombs because now it's directly coming from the baby, right? And now if the baby is Rh negative like mom, we're great. We don't have any issues, okay, because she didn't have issues while she was pregnant, and we didn't have any problems when she, and now afterwards we don't have to give her anything, okay? If it's positive, if her Coombs is positive or her blood type is positive, okay, we're going to give that mom Rogam again, okay, up to 72 hours before she leaves the hospital, basically, okay, because, again, the possibility during birth of that blood exchange could have occurred. So since that could have occurred, we're going to then be able to give her, we have to give her Rogam again. If it's positive, we have to watch the baby too, because the baby now is going to have antibodies. So it's going to cause its own hemolysis, and it's going to start to get jaundice very quickly. So sometimes your babies come out great, they're fine, and like at 18 hours, you start to look at them and they start to glow. And they start to get really yellow. And you do a bilirubin test, and they went from like, a 4 to like a 9, in 18 hours. And you're like, what the heck? Normal is like under 4. You know what I mean? And now they're 9. And usually these babies they go so high that before they even leave the hospital with mom, they're already putting them under the phototherapy lights because we have to bring that bilirubin down. So that's what we're trying to prevent, okay? So we're trying to prevent the baby from getting high bilirubin levels like that. So that is your major. Your ABO is not as bad. Yes, your babies will get jaundice with it as well, but they usually don't have the risk of having kernicterus on an ABO because your body can tend to try to fight it off a lot easier than with the Rh negative, okay? There have been cases with ABO where we've had to do what they call it's almost like a blood transfusion on the babies where we give them, let's say, their type blood, We give them, let's say if they're A positive, we give them A positive blood to kind of flush out all the O that's in them from mom, and that usually kind of fixes the problem. So, but ABO isn't as bad as your RHs. Your RH is a much more severe condition. Amniotic fluid imbalances, again, this is, you have your 2 levels. So this is water in the pool, right? Water in the pool should be within a normal range, right? So you either have too much water or too little water, but you have to have the right amount. So if you have too much water, it's called polyhydramnios. If you have too little water, it's called oligohydramnios. Right? Remember, poly means more, oligo means little or less. So those are your terminologies. Polyhydramnios, things that can cause it are going to be more associated with some type of fetal anomaly. We're talking about more than 2,000 mLs by the time she's 32 to 36 weeks. So this is an overfilled pool, right? We want things to float, but right now the water is like over the top, okay? And now there's so much room in there that the baby can't even engage into the pelvis because it's just floating in so much water, okay? So when you've got so much water, things float, but babies end up floating too. So their position is going to be very what they call transitional, meaning that they're not able to just fall into the pelvis because the water is kind of keeping them out. It almost causes that buoyance, right? The water, so much water, it does not allow them to fall into the pelvis, okay? And it also tells us that there's some type of fetal anomaly going on in development. So these babies either have something wrong with their development. Most of the time, it's either something that doesn't allow the baby to swallow, okay? Because remember how the babies maintain their water, right? The water in the pool. They swallow and pee, swallow and pee. So when they swallow the water, they can swallow it and they pee it out, right? And then that fills up the pool again. They swallow it, they take some down, they pee it out, they put some back in, okay? However, when you have a baby that has like an esophageal issue or esophageal atresia where they're not able to swallow, they can't swallow the water, but they're still peeing out water. So that's why it gets overflowed, okay? These babies do end up in the NICU for the most part. Issues are with too much fluid being produced or with fluid being taken up or both, and treatment may include close monitoring and frequent follow-up. There's really much that we don't do with poly. We don't have to induce them, really, unless there's issues with the baby. With polyhydramnios, we just have to watch with their position, because what happens is that when her water breaks, right, it's going to be one wet ride, right? And if things are floating in there, the first thing that could come out besides the baby's head or come down into the pelvis besides the baby's head is the cord. Okay, we'll talk about cord prolapse in a minute, but that's one of the other big things that can occur. Oligohydramnios is too little fluid. So she's got less than 500 mLs in her pool by the time she's 36 weeks. And these things is that baby's not having the ability to pee it out. So there's something wrong either with the baby's kidneys or with the baby's ability to pee. Okay? Now when you've got too little fluid, the opposite happens. Things don't float. Right? When things don't float, they get stuck. When they get stuck along the walls, right? If the baby kicks or if the baby moves and kinks, it's going to kink a lot easier. When you kink a cord, you have a variable, right? The heart rate goes down because this is the lifeline of the baby. So you think of your cord as your lifeline. If you're kinking it or if you're pressing on it, you're not letting oxygen to get through. So the baby's going to have a lack of oxygen. It's going to have a dip in their heart rate. Okay, so you're going to have a lot more variables, okay? And with oligo, things don't develop as much. So she doesn't have a lot of fluid. Babies can't float. Babies' organs and joints and things like that can't grow and get fully functional. So babies have issues with tone or with or with reflex because they're not able to kind of float in this water and kind of stretch out those limbs. Okay, so that's one of the other big things that occurs. So these patients, usually we watch them as much as we can. We try to do expectant management to try to get them to term as close as possible. But if we can't, we're going to induce them and deliver them early. Okay, unless there's an issue with the baby, we're not going to really do a C-section. We're just going to end up trying to induce them. And then premature rupture of membranes. So water breaks before she goes into labor. Basically, that is your thing. So you've got no labor. She's walking in Walmart. Her water breaks. Boom. Right? Preterm is that it happens before she's 38 weeks. Right? So she's 36 weeks or 35 weeks. Walking in Walmart. Boom. Her water broke. Right? And then prolonged is that now her water's been broken for more than 18 hours. Okay, so remember what happens. All the water comes out. Now, yes, the baby pees and more water gets pulled in the pool, but the pool has a hole in it. Right? So there's only so much water that can kind of collect in that pool with the baby in it. All right? So when you've got a long time of where there's no water in the pool, right, the cord has a better chance of being kinked because it's not floating. Okay? Now, if you look at that picture, the great thing about it is that the baby's head will serve as a cork. Okay? So the water breaks and the water comes out, but the baby's head drops into the pelvis and it'll act like a cork. And whenever the baby wiggles and moves, the mom's going to feel a big gush. And that's usually what happens. Mom wiggles and moves, and all of a sudden she feels a big gush now. Why am I leaking now? I wasn't leaking for hours before. Now I started to leak. Yeah, because the baby's head shifted and all the water came out from behind the baby. Okay, but we rather have a lot more fluid in there because then the things behind the baby will float, meaning the cord, the baby's limbs, and so things don't get kinked as well or as often because of the fact that it's still floating. The way we diagnose it is basically we can see water coming out of her vagina. It's very clear. We could also put a sample of the water under the microscope. And they have what they call is called ferning. And ferning is basically the type of cells that we see in the amniotic fluid. And they look like little fern trees. They look like little Christmas trees. So they have like this little shape where they're like this. Okay, and then there's that kind of shape on the cells. Okay, so they have like the shape and we call it ferning. Then we can see that. And the nitrazine paper. So nitrazine paper is like pH paper. pH paper. Amniotic fluid is it's alkaline. It's acidic. So what happens is that it'll turn the paper blue. Okay, so if we put a piece of pH paper on the sample of water, and we put it, it'll turn bright. It'll turn like a real royal blue, like almost like the color of your scrubs. Okay, and that's how we know she broke her water. The other way we do it now too is we use an AmniSure, which is the same thing as using the pH paper. Use a Q-tip. Put it in the sample, send it to the lab. It tells us whether they saw ferning or not. Okay. We used to be able to do ferning in our own lab, like in our own room. The doctors used to be able to get a sample and look under our own microscopes, but now we can't do that anymore. They took the microscopes away. I don't know why, but they did. Risk factors, again, if it happens too early, it could cause a premature birth. The other thing that can happen is that cord prolapse can occur, and then you could have chorioamnitis. Now, chorioamnitis is, again, it's an infection of the lining of the uterus. So remember, the bag is what protects your baby, right? It's your balloon. It's what protects your baby. When the bag of water is broken, all that wonderful vaginal flora that's in the vagina that kind of loves to sit there, right, and protect us, it now can ascend upward. When it ascends upwards, it can cause an infection in that lining of the uterus. Okay? And that's called chorioamnitis. So that's why if she's been ruptured for too long, we're going to give her antibiotics because we want to prevent that from happening. Because we need to make sure that we're covering her and not letting her get an infection. All right. And I'm going to give you guys a 5-minute break because from here on in it gets a little heavy. Now, hypertensive disorders of pregnancy is going to be your big bulk. This is what you guys really need to kind of study on, okay? The other stuff, if you follow your PowerPoint, you follow what's on there, those major topics of the PowerPoint, and you know them, at least the bare basics, you'll be fine. This stuff you really have to kind of read and you have to study, because this is going to be a big part of not only your exam, but also a big part of your ATI, maternal newborn proctored exam, your ATI practice assessment that you guys have. So, and it'll be a big part of your end of program at the end of level 4. Okay, so hypertensive disorders of pregnancy is a big deal. It's one of our biggest topics. So we start off with chronic hypertension. And chronic hypertension is hypertension that is going to occur before you are 20 weeks. These patients are usually your patients that come in already with hypertension. So it's a blood pressure higher than 140/90 before pregnancy, or at least before 20 weeks. When we see a patient in the office that her blood pressures, because remember the dynamics when we talked about in your antepartum. Initially, when you first get pregnant, the blood pressure drops, right? As your body starts to adapt to the pregnancy, your blood pressure drops. Once it hits about the second trimester, it starts to normalize, okay? And then if it's going to go up, it's going to go up again in like that third trimester, okay? Now, if we start to see a patient that has elevated blood pressures before she's 20 weeks, the red flag is going to go up. We're going to be like, okay, this patient was probably hypertensive and wasn't either getting treated or didn't even know it before she got pregnant, okay? It's very rare that you have preeclampsia. Preeclampsia does not occur before she's 20 weeks. It's not preeclampsia, okay? It's chronic hypertension, all right? Now, if she starts to show signs where she's spilling spilling protein in her urine after 20 weeks, then it becomes preeclampsia, chronic hypertension with superimposed preeclampsia, because now she's got protein in her urine, okay? But if she's under 20 weeks, and that's when we start to see those elevated blood pressures, it's not preeclampsia. It is chronic hypertension, okay? 20% of childbearing women have chronic hypertensive, and 25% of women with chronic hypertension will develop preeclampsia. So those are your stats. That's your prevalence, okay? Management, for the most part, mild chronic hypertension does not require hypertensive therapy. So it doesn't require meds for the most part, okay? Now, for any patient, whether it happens in the beginning of the pregnancy, the middle, or the end, if her blood pressures are in that 160/100, remember we called that the hypertensive crisis, right? So if she's in a hypertensive crisis, we're going to treat her no matter what, no matter where it came from, all right? If her blood pressure is at that high, she's in a crisis and needs to get treated, okay? So we're going to give her labetalol, we're going to give her IV therapy to be able to bring down that blood pressure. If it doesn't bring it down, okay, we're going to give her the bigger guns. We're going to give her magnesium sulfate or something to help bring down that blood pressure, because she's in that crisis, okay? Now, at this point, what's causing the crisis, if she's pregnant, is her pregnancy, okay? So then we have to decide how detrimental it is where she's at and how early the baby is. Okay, because the only other way of being able to cure her and bring that blood pressure down is delivering her. Okay, so if she's 25 weeks and she's in a crisis, we're going to try everything in our power to keep her pregnant, right? So we're going to give her whatever meds we have to give her. So whether it be labetalol, hydralazine, magnesium sulfate, whatever we have to give her, that's in our arsenal to keep that blood pressure down. Okay, because we don't want to deliver her at 25 weeks if we could avoid it. Okay, so that's the key. But with chronic hypertension, the biggest thing that you need to know is that it occurs before 20 weeks, and it's elevated blood pressures that happen either when she's already before 20 weeks or before she even got pregnant. Now, gestational hypertension is going to be your blood pressures that start to be elevated in her pregnancy. So it happens after the 20th week of pregnancy. And it usually with patients that were normotensive, so they didn't have any blood pressure problems prior to being pregnant or in the early parts of her pregnancy. So before she was 20 weeks, she didn't have any problems with her blood pressure. She was fine. She didn't have any swelling. She didn't have any headaches. She didn't have any symptoms of blood pressure issues. Okay? Now she's 24 weeks, and her blood pressure is creeping up. Okay? And it's either 140 or higher or 90 or higher on 2 occasions, at least 4 to 6 hours apart. Okay, so basically what ends up happening is that she comes into the office, we take her blood pressure, it's like 142 over 89. They document that, they let her see her doctor. Before she leaves, they take her blood pressure again. Okay? And then now it's like 138 over 87. And they're like, okay, it's low, it's back down again. We just watch her. The doctor might even say, you know what, I want you to buy yourself a blood pressure cuff and take your blood pressure twice a day at home. Like in the morning and at night. And keep a log. Okay? So we want to see what the pattern is. Okay? So sometimes the diagnosis of gestational hypertension is going to take a little bit to happen because she may end up having to do a log. We're not going to keep her in the office for 6 hours to take her blood pressure again. Okay? Now, if it's her first time and they did it in the beginning of a visit and it was 142 over 89, right? And then they did it again. And then the second time before she went home, it was 144 over 92. Now it was 2 of them were both high. So now that patient will be sent to us. They'll get sent to the hospital for an extended evaluation. So they're going to want to do serial blood pressures on her in the hospital. Okay, so she'll come and stay a few hours in our triage to do our blood pressure, to do blood pressures on her. Okay, to see what they're doing, what they look like. Okay, now it could be that she's just nervous and she's freaked out, and now her blood pressure, she comes to us and we leave her on every 10 minutes and all her blood pressures are great. And we can send her home. Okay, but maybe they're not great and maybe they're higher and higher and higher. Okay, and usually at that point, they may talk about giving her some type of oral medication to be able to give her something. All right, so temporary diagnosis of a hypertensive patient, women who do not meet the criteria for preeclampsia or chronic hypertension. Gestational really kind of like is that patient that's on the fence. Okay, she's having these elevated blood pressure. She's over 20 weeks. We could tell her, okay, let's do lifestyle modifications. So, rest, watch your diet, low sodium, those kind of things, right? And then we take her blood pressure periodically again, okay? Or it just kind of stays at 140 over 90, okay? Never has protein in her urine, but she's going to need some oral medication to get that blood pressure down. Okay, and these are the patients that start with like labetalol, 200 milligrams twice a day. Okay, or 100 milligrams twice a day. So that way we can be able to kind of bring down that blood pressure and keep her within that normal range. Now the goal is always to keep her in that normal range. The reason why is because we know that hypertension can cause vasoconstriction of the placenta. Right, so when we have vasoconstriction of the placenta, we end up building calcified areas of the placenta. When you have calcified areas of the placenta, you have areas where there's no perfusion that occur. When you don't have perfusion, you have areas where the baby's not getting oxygen. The baby's not getting oxygen, the baby's getting hypoxic, baby can't grow right, baby starts to have issues with their development. Okay, so the goal is always to have a normotensive patient, okay, because that way it helps with the perfusion of the placenta. So now we have preeclampsia. Now preeclampsia is a multi-system vasopressive disorder, okay? It's going to target your cardiovascular, your hepatic, your renal, and your central nervous system, okay? And it can be classified as both mild and severe. All right, so preeclampsia is just not elevated blood pressures that are really bad, okay? Preeclampsia now, it starts to affect other organs of the body. Okay, so she doesn't only have elevated blood pressure, but now her kidneys aren't working. Okay, and when her kidneys aren't working, she's spilling out protein that she shouldn't be spilling out. Okay, so pregnant women should never spill out more than trace amounts of protein. Okay, trace amounts is normal in a pregnant woman, but if you start to have +1, +2 on a dipstick, okay, of protein in her urine, that's too much. Okay, if you do a 24-hour sample of her urine collection and you run it for protein and you have more than 300 milligrams in a 24-hour sample, that's too much. Okay, and that's preeclampsia. So it's going to affect her kidneys, it's going to affect her liver. Okay, so her AST and her ALTs are going to be elevated. So her liver function tests are going to be elevated because it's affecting her liver. Her blood pressure, her elevated blood pressure is affecting her liver. It's going to affect her central nervous system. She's going to start to have central nervous system symptoms. So it's going to be blurry vision, headaches, okay, epigastric pain, all right, swelling of her hands, of her feet, of her face, okay, all symptoms of that are going to be now affected by her elevated blood pressures. So preeclampsia is a continuum. It's a phase where if it starts off and you start to see it, when it's mild, we can control it. When it's severe, we're looking to deliver her, but we have to outweigh the risks and the benefits for that baby. How early is she? Is she really early that we're going to have a preterm delivery? Or is she really severe that she's circling the drain and we're better to have a healthy mom and worry about a baby that could be in NICU? Okay, so that's what we're dealing with. In your book, I put that there. If you open up this is through Docere, but if you open up your PowerPoint and you press on comparison chart, it'll give you the link in your book of the comparison between like your chronic hypertension, your gestational hypertension, preeclampsia, mild and severe. It gives you that nice chart that's in your book. That's going to be a good study guide for you. Okay, so that part of the book will be a good study guide. Pathophys behind your preeclampsia, again, consists of generalized vasospasms, which result in elevation of blood pressure and reduced blood flow to the brain, liver, kidney, placenta, and lungs. And that's why I said placenta is key. Those calcifications, when mom's blood pressure is high, causes less perfusion in our babies. Okay? And we could actually see that. For those of you who have already been to OB, if you get a chance to look at a placenta, right? Look at the placenta, feel it. If you see white patches on it, right? Those white patches are calcifications. You could actually feel the roughness of them. Okay? My group yesterday, I was able to play show and tell and actually get a placenta on Tuesday and be able for them to feel it. And it had calcifications. And they could rub their finger on it and you could actually feel how rough it is compared to the soft tissue of your regular good perfusion placenta. Okay? So it doesn't allow that area to perfuse anything. So the baby's not getting any oxygen through there. So if the more of those patches that you have, the less baby is going to get. Okay? So that's one of the big things. Therapeutic management, it's always going to vary on the severity of the mom's condition, okay, and how it affects the baby. So it's a constant monitoring that we do for this mom and this baby. Okay, so for mild preeclampsia, we do conservative strategies. So we know she's got protein in her urine. Her liver function might be okay, so we're going to monitor her, okay? We're going to bring her in, 2 times a week or so, do non-stress tests, do biophysicals to test for fetal well-being. We're going to do serial blood pressures. If she's on medication, make sure she's taking her medication. So everything to be able to kind of say, yes, we're monitoring her and we can continue to wait, right? We want to keep her pregnant for as long as possible, but as long as mom is stable, okay? Now, severe preeclampsia may happen pretty suddenly, okay? And now her blood pressures are getting into that hypertensive crisis zone where they're above 160 over 100, okay? They start to have a lot more proteinuria, meaning that now it's not just it's just not over 300, now it's over 500 or 5 grams, okay, in a 24-hour sample. Now she's barely peeing out. So you barely got 1,000 mLs in 24 hours. Okay, so it's affecting her kidneys even more. Her cerebral and visual disturbances. So now she's not only seeing, now she doesn't only have blurry vision, but now she's seeing spots and halos. Okay, now she's got a headache that doesn't go away, even without as much Tylenol as we give her. Okay, and then she starts to have swelling. Okay, so rapid weight gain is going to be from all of that swelling. So now her face is going to be swollen. She's going to wake up and she's going to look like a chipmunk. Okay, she's going to have her hands much more swollen. Swollen feet are normal in pregnancy, but this is going to be swelling that goes all the way up to her knees. Okay, so you're going to have all her knee, from her feet all the way up to her knees, swollen. Okay, she's going to have epigastric pain right under her bra line. Okay, where now she's going to be feeling like heartburn, almost like that really bad heartburn that women would get. Okay, all of those are severe signs of preeclampsia. And when we get to that point, we're trying to see, okay, how early is she? Can I safely deliver her, get her through this, and have a safe baby? Okay, if I can't, if she's too early, I'm going to try to buy some time. Okay, the way I buy some time is by giving her magnesium sulfate. Magnesium sulfate helps to protect the baby by doing neuroprotection because it helps to protect the baby, keeps her blood pressures lower so that I could buy a day or two. Okay, the other thing I give her is I'm going to give her betamethasone, okay, which is your steroid for your baby's lungs, because I know that eventually I'm going to have to deliver her. Maybe not today, but maybe in 2 days, right? So I'm going to want that baby to have the best chance to produce surfactant on their own so that they could be able to breathe outside of mom. Because if not, then I'm going to have a baby that's going to be compromised. So I want to give that on board. So the reason why I give her mag sulfate is to buy time. It's to neuroprotect the baby and to buy some time. It's not to keep her on it indefinitely. Okay, so we don't keep her on it now anymore. So basically the most she's on it is basically 24 to 48 hours. After that, we're deciding to do something. We're delivering her or something, okay? And then eclampsia is going to be that she ended up having a seizure, okay? Eclamptic is basically she has a major seizure due to her blood pressure, okay? And that's going to be your big thing. Assessment. So assessment is going to be if she's got blood pressures higher than 140 over 90, right? She's got proteinuria in a 24-hour urine sample or +1 in a dipstick. And there's no evidence of a UTI. So we're ruling that out. It's not a UTI because there's no nitrates, there's no leukocytes, it's just protein. Okay? We're looking for those risk factors. So those other things, epigastric pain, headaches, blurry vision. Okay? We're looking for edema, what her blood pressures are. Okay? And we're looking for DTRs, and I think that's a typo. It's that STRs is DTRs. So it's your deep tending reflexes. Okay? With preeclampsia, they're going to be hyperactive. So you're going to hit her knee, and her knee's going to go floop, and it's going to fly high. Okay? Because they're going to be hyperactive with preeclampsia. Remember, there's that neurologic effect. Okay? So they're going to be super high. She's also going to have something that we call clonus. right? So if I take her foot and I push it down, okay? If I push it back up, it's going to go, it's going to bounce. It's going to spasm, okay? That's clonus. And you can actually count the number of times that it spasms, okay? That's going to be clonus times 2 beats or 3 beats, okay? And that's going to be another sign. So these are my signs that I am looking for a patient to be in severe preeclampsia or even a really mild preeclampsia. So I'm always doing DTRs. I'm always doing checks for clonus. So if I know my patient, if I come in the morning and my patient has preeclampsia and she's there for observation for preeclampsia, this is part of my physical assessment. So yes, I do heart, lungs, and abdomen, and I check, but now I'm checking specifically for signs of preeclampsia. So I'm looking at her edema and where it is. Is it pitting? Is it not? Is it how high it is on her thigh? Okay. I'm listening to her lungs, making sure that her lungs are clear. Okay. I'm checking her DTRs. I'm checking her clonus. Right. I have her on serial blood pressures. Okay. Usually it's every 2 hours while she's awake. I'm doing these assessments because that's part of what I need to be able to figure out how well she's doing, or if she's at least stable. Is she getting worse, or is she at least stable? Okay? Better she can't get, because once she's got these things, it's not going to go away until after she delivers. Okay? But at least I want her to be stable, that I'm buying another day. Because every day that I buy is better for the baby. Okay? So management, again, focus is close monitoring of blood pressure, ongoing assessments for evidence of any disease progression. Again, teaching guidelines, you'll be able to click on that link, and it's going to tell you the things that you need to teach your patients while you're doing your assessments. Okay? Mild preeclampsia, if they're at least stable, they're probably not going to stay with me, okay, at the hospital. They'll be able to go home and come back and forth to do their non-stress tests, to do their biophysicals, that kind of stuff. Okay, serial blood pressures, all of that. But I'm going to make sure that they're monitoring and that they're compliant. The minute they fall off that scale, that they're not compliant, or their blood pressures are wacky, or they start to show more signs or symptoms, they're going to stay. They're buying themselves a night. Okay? And then severe preeclampsia is always going to require hospitalization, because we need to monitor that baby. Okay, if she's in severe preeclampsia, we have to monitor that baby to make sure that that baby is getting the adequate perfusion that it needs. Because if not, then what's going to happen is that the baby's going to show me in the monitor strip. So as the reactivity goes on, it's going to show me that it's not getting enough oxygen. Okay, and then HELP. HELP is an acronym that that we use to be able to signify your most severe symptoms of severe preeclampsia. So it's an acronym to help you to remember the elements that are involved in severe preeclampsia. And it stands for, H is for hemolysis, EL is for elevated liver enzymes, and LP is low platelets. You'll only be able to find HELP as a clinical laboratory finding. So it's not an assessment, it's labs. We do labs on our moms that have preeclampsia, mild to severe, and when we start to see these elements occur, we are then going to be able to say that she is in HELP. Okay? Now her severe preeclampsia has turned to HELP. Okay, so at this point, delivery means that we really need to kind of get it going. We need to get her delivered, because now she's affecting all the elements that are going to make mom at a greater risk for issues, and baby risk for issues as well. So now her platelets are dropping. Now her hematocrit is dropping. Okay, and her liver function tests are going up. So her liver's failing. Her platelets are going down, okay? So she's circling the drain, okay, like we like to say. She's circling the drain and she's getting much more ill, okay? So these are life-threatening obstetrical complications. It's considered to be to many to be a very severe form of preeclampsia. It involves all of your thrombocytopenia, your hemolysis, and your liver dysfunction. Usually, moms that go into help are going to be somewhere between 22 and 36 weeks of gestation. Okay? That same period of time where they're going to start to show gestational hypertension or preeclampsia. Okay? So, a mom could be 18, start to have pregnancy, be okay until she's 23 weeks or so, 24 weeks, and then all of a sudden start getting sicker and sicker and sicker and sicker. Okay? Your risk factors remember when we talked about risk factors for hypertension, they're going to be your very young and your very old patients. So you're under 15, you're over 35. They're going to be much more prone to getting preeclampsia and eclampsia. Okay? What could happen to them? They could have a cerebral hemorrhage, a retinal detachment, hematoma, a liver rupture, acute renal failure. They can go into DIC, which is what I spoke about. Their placenta could erupt because, again, remember, hypertension is a vasoconstrictive process. So if you're vasoconstricting that placenta so much, okay, because their blood pressures are so high, the placenta is going to go and pop off. Okay, and you could have an abruption. And your mom could end up dying. Okay, so with severe preeclampsia and HELLP, it is a obstetrical emergency. Treatment, again, it's going to be based on your severity. It's going to be based on your gestational age. What's the actual condition of the mom? Priority is to decrease the blood pressure and to prevent your seizures. So you don't want to get to the point where they're eclamptic. Okay? You want to be able to bring down that blood pressure, bring them down to the point where they have normalized blood pressures or at least under the elevated range so that way we prevent that seizure. We're going to give them steroids for lung maturity to make sure, because we know eventually we're going to have to deliver her, okay? And then again, delivery of the infant is the only cure, okay? Now, yes, preeclampsia can occur postpartum as well, because remember, you still have the same hormones and the body is still now trying to adapt and get back to that pre-pregnant state. So it is a condition that can either happen prior to her delivering, or that she could be fine throughout the whole entire pregnancy, deliver her baby, and then get it 6 to 8 weeks after, okay? But usually after 8 weeks, it doesn't occur. If she starts to have blood pressure issues after 8 weeks of postpartum, she's chronic, okay? Just like she was when she was under 20 weeks, she's chronic. So on either end of the spectrum, it's back to chronic hypertension. But while she's pregnant, in between 20 weeks and 6 to 8 weeks postpartum, it can still be preeclampsia, especially if we have a lot of those symptoms. Okay? All right.